All right, well, welcome to the next team-based learning day. We've been talking about the heart and the cardiovascular system, the blood vessels, and a little bit about the blood. And now we're going to talk about the two aspects of the blood, which are important. One is blood typing, and then second is blood clotting, also known as hemostasis. All right, so one thing to know, and we're going to jump into the blood typing first. All of our cells have proteins sticking out of the cell membranes. The proteins on the red blood cells, or RBCs, are specialized proteins. There's many of the proteins that everybody has, the same proteins of on the red blood cells, like sodium potassium pump, sodium channels, things we've talked about. But then there's some that are unique to each individual, and we call these antigens. Blood groups are and the blood groups like type A, type B, O, all those different ones are according to the antigen that people have on their blood cells. Okay? And really what antigen means is antibody generating. And that's really what it means is that it's a type of protein on a cell that if the immune system interacts with it, it causes the immune system to generate an antibody. And that's what the antigen means. So if you don't have a certain antigen, like if you don't have the A antigen on your blood, then you have an antibody for that missing antigen. Okay, so the reason it's so important to understand blood types and to get the right type of blood when you get a blood transfusion is because it's a life-threatening situation if you get the wrong type of blood. The reason for that is kind of shown in this image here, but what happens is the initial reaction if you put the wrong type of blood in, we get something happening called agglutination. That really means when the blood cells start sticking together. Okay, when the blood cells start sticking together, we see that right here in number 2. Okay, we see these antibodies here, these yellow things are antibodies. One stuck to one red blood cell here, the other one stuck to one here, and that sticks them together. And that ends up causing big clots, big clumps of blood in the vascular system that can clog blood vessels and lead to lack of blood flow. Eventually that leads to those cells rupturing or also being phagocytosed by cells of the immune system. And then we get hemoglobin dumping out into our bloodstream, and there's lots of consequences of that. Number one, obviously, if we have red blood cells dying or clogged blood flow, then we have decreased oxygen carrying capacity of the blood, decreased blood flow with that clotting, and secondly, lots of hemoglobin in the blood leads to hemoglobin building up in the kidneys, and that can actually acutely destroy the cells of the kidneys and lead to renal failure. And that can be the life-threatening situation with a transfusion, with the wrong type of blood being transfused into your body. So the human blood groups, we'll start with the RH factor. RH factor is first discovered in rhesus monkeys, and that's why it's called RH. About 85% of Americans are RH positive. That means that they have the RH antigen. Okay? Antibodies are typically not spontaneously formed for the RH antigen, which is different than the A and the B antigens. Okay, so it normally takes about 2 infusions to cause a serious reaction against the RH antigen. So the problem with this really comes in pregnancy. So when we have a mom that is RH negative, shown here, okay, and then we have a baby who's RH positive who does have the antigen for the antigens here for RH, then what can happen is that the antibodies that mom has produced, which are here in the yellow squares, those can actually get in and destroy the baby's red blood cells. Okay, so usually in the first pregnancy there aren't typically any problems because the blood doesn't really mix till the very end. Most of that mixing happens during delivery. So the mom hasn't really generated antibodies yet against the RH antigen, and so, but then during that delivery process, lots of blood mixing occurs. That causes mom to generate antibodies against the RH. So then during the second pregnancy, If the baby again is Rh positive, then the mother's antibodies will destroy the baby's red blood cells. It leads to what's called hemolytic disease of the newborn, which can lead to some very problematic developmental delays or death. And so now if the mom is Rh negative, they just automatically give a drug called Rogam. And Rogam contains antibodies against the Rh antibodies, and so if mom does have those antibodies, this drug will destroy those. And it's given at 28 weeks, and then again within 72 hours of delivery to make sure there's no problems with that. So that's the Rh factor. Secondly, the ABO blood grouping is a similar idea, except there's just two different antibodies. So we talked about the Rh antibody. Now we have the A antibody and the B antibody. Okay, so if somebody's if somebody's blood is AB, that means they have both A and B antibodies, and it means they don't have either of the antigens. Okay, so this table kind of walks you through it. This row is AB, this row is B, this row is A, this row is O. Okay, so let's start with the AB. AB means the red blood cell does have both A and B antigens. So then which antibodies does it have? None. All right, so it doesn't have any antibodies because it has both of the antigens, and so if it had the antibodies, it would destroy it. So the blood that somebody with AB can receive is all of the bloods, all right, all the different types, because this person is known as a universal recipient. And so the idea here is that you only can the only thing that becomes problematic with your blood type and receiving bloods is which antibodies you have. And so since this one has no antibodies, they're the universal recipient. Okay, secondly, B-type blood obviously has the B antigens. So that means they have B antigens shown here, but they also have the anti-A antibodies. Okay, so what that means is they can't receive A blood, but they can receive B and O blood. Okay, A antigens obviously have the A-type blood has A antigens shown here, and then it has the anti-B antibodies. Okay, shown there, and so they can receive. They can receive any type of blood except for the B type. Okay, and then O blood doesn't have any antibodies, so no antigens, and that means it has both antibodies, type A, anti-A and anti-B. Oops, sorry. So that means they can only receive type O blood, but they are the universal donor. Okay, and we'll get into that a little bit more in class, and we'll add in the Rh factor and how that plays into that when we get to the TBL day. Okay, so let's talk about the whole blood clotting process. The blood clotting process is really a series of events where a protein is changed from an inactive protein to an activated protein, which is a whole cascade of events. Okay, and we'll get to that cascade here in a second. But the thing to talk about first here is what's happening normally in the blood. We just have normal blood flow. No blood vessels are broken. There's no bleeding happening. This is just a homeostasis period in the blood. Okay. We have what's called anti-hemostatic mechanisms that are dominating. Okay. This is a different word. Homeostasis and hemostatic are two different words, right? Hemostatic means blood clotting. Okay, which is different than homeostasis, right? So during homeostasis, anti-hemostatic mechanisms dominate, and those anti-hemostatic mechanisms are those intact endothelial cells. They release something called nitric oxide as well as prostacyclin. Okay, we also have basophils and mast cells. Those are immune cells, different types of immune cells. They both release a chemical called heparin. Okay, all of these factors right here, these are both anti-clotting factors. They stop you from clotting. Okay, and then we also have what's called fibrinolytic factors that dominate. One of those is called TPA, or tissue plasminogen activator, as well as plasmin. Okay, what this means is breaking down clots. Okay, so if clots start to form, TPA and plasmin act to break down any clots that form. Okay, so again, these top two, the endothelial cells and what the basophils release, those are just clotting agents. And then these ones are actually breaking down clots that have already formed. So that's what it is during homeostasis when there's no bleeding occurring. But then what happens when we have a vascular injury? Okay, so just picture that you just were shaving, maybe, we'll use that example. You're shaving, you cut yourself, so you broke the skin, you also broke some blood vessels. So the first goal of the body is to decrease blood flow to that area, right? Because we want to minimize blood loss. So as soon as blood bleeding starts happening, we want to stop sending blood to that area. And the way we do that is by vasoconstriction or vascular spasm. All right, so we vasoconstrict the blood vessels going to that area. It looks like this, right? We go from a broken blood vessel here, and that moves us over to these blood vessels getting smaller. We vasoconstrict, okay? That's caused by just direct injury to the smooth muscle. When that smooth muscle is damaged, it causes contraction. When endothelial cells are damaged, they release chemicals that cause vasoconstriction as well. And then also, whenever there's cellular damage, we have pain receptors stimulated by the stuff inside of those cells. That also causes spasm. Okay, and then the more tissue damage we have, the more spasm that occurs. Okay, and so the function of all of this is to slow down blood flow to allow time for the platelet plug to form, which will be the next step. Okay, so step number one when we have a bleed is slow down blood flow to that area by vascular spasm. Okay, step two is trying to get the platelet plug to form. Okay, so platelets, we've talked about them already. We talked about the blood. They are kind of these particles of cells that are very important for the blood clotting process. And they're activated. They're normally just kind of floating around in this form, in this inactivated form. Okay, but then when they come in contact with collagen, that immediately activates them. Okay, that makes them swell, and it makes them become sticky. So they go from this kind of flat form to kind of swell in here in the middle, and then eventually they kind of form these little tentacles that are sticky, and those start sticking to everything around it. Okay, so that's the process of platelet activation. Okay, so why would they come in contact with collagen? Because there's collagen in the tissues, right, around blood vessels. So when we have a broken blood vessel, collagen then interacts with the blood. So as soon as that collagen comes in contact with platelets, it causes those platelets to become activated. And so when they become activated, they start releasing a couple chemicals. They release something called ADP. You guys know that, adenosine diphosphate instead of triphosphate. Okay, that's a potent aggregating agent. It causes all the platelets to kind of aggregate in that one area. They also release serotonin and thromboxane A2. Okay, both of these cause lots of spasm as well as more platelet aggregation. Okay, we're going to come back to all three of these later when it comes to blood clotting drugs. Okay, so step one in the platelet plug formation. Okay, so we've got in this image here, we've got the blood vessel here. All right, we have a break in the blood vessel that's shown by this. All right, blood is leaking out here, right, leaking out into the tissue. Some collagen. These collagen fibers shown here are interacting with the platelets. That causes them to start forming a plug. Okay, so the step one is platelets stick to the exposed collagen fibers. We see that here. All right, step two is all those same drugs or all the same chemicals we just talked about are released. That causes aggregation. All right, so we see lots and lots of platelets come into the area. We see quite a few there, but even more here. All right, so it causes them to aggregate, and then this eventually causes the platelet plug to form in about a minute. Okay, so you guys may be able to recognize this on yourself. It's kind of a gross thing to think about, but when you pop a zit, which I know most of you have probably done, when you pop a zit, sometimes at first after you pop it, there's some blood that comes out, but then within about a minute, blood doesn't keep coming out, but some watery liquid kind of leaks out. All right, and that's after the platelet plug is formed, because the platelet plug is tight enough and sealed well enough to not allow red blood cells to get through, so we don't see blood anymore. but it still allows plasma to leak through, and that's that watery substance that can still leak through the platelet plug. Okay, so the overall steps of hemostasis. Number one, we got vascular spasm. Okay, talked about that. Smooth muscle contracts, vasoconstriction. Number two, we got platelet plug. We just talked about that one. Okay, and then step three, which is the longer step now, is the whole protein cascade called coagulation, where fibrin forms a mesh that traps our blood cells and platelets, forming the clot. Okay, so we got vascular spasm, platelet plug, coagulation is where we're going to go next. Then we're going to talk about clot retraction and thrombolysis. Okay, and this whole process that we're going to talk about only takes about 3 to 6 minutes. Okay, so let's hop into coagulation now, the last step. Coagulation is, the whole idea of this is to reinforce the platelet plug with a glue-like substance, and that glue-like substance is fibrin. Okay, the blood changes from liquid to more of a jelly-like substance. The clotting factors that we're going to talk about, they're all plasma proteins that are made in the liver, for the most part. Okay, vitamin K is needed for the synthesis of at least 4 of these clotting factors. And a couple things to remember: each phase that we talk about has an end goal. So you're going to want to note what the end goal of each phase is. And the whole key is that each step involves one factor clipping part of a protein off, and that makes it become an active enzyme. Okay, so protein to enzyme is really the key thing of all of each step of the clotting cascade. All right, so the next step here is looking at the overview of the clotting cascade, and really there's 3 phases. And so phase 1 is the only one that has 2 options. There's intrinsic or extrinsic pathway, but the bottom line is both of them lead to the formation of factor 10 or factor X, and then factor X combines with other factors to form what's called prothrombin activator. And so this is the end goal of phase 1, is to create prothrombin activator. Okay, but again, both the intrinsic pathway and the extrinsic pathway lead to factor X or factor 10, and then after that, factor 10 leads to the formation of prothrombin activator. So that's phase 1. Phase 2 is the same, no matter what. There's not 2 different pathways. That was only in phase 1, and really the big step in that is that prothrombin is converted into thrombin. So thrombin is the goal of phase 2. Thrombin. Okay, and then phase 3 is thrombin is used to change fibrinogen into fibrin, and fibrin is the goal here, and this is really what makes the clot. If you look at all these kind of whitish fibrils in a blood clot, that's fibrin. So fibrin is really the end goal of the whole clotting cascade. Okay, so let's take a look at each of these phases with a little bit more detail. So let's start with the phase 1. And again, there's intrinsic and extrinsic pathways for phase 1, so 2 different ways to do this. Okay, the ways that they're similar is they're both triggered by tissue damage. Okay, so when tissue damage occurs, that starts this whole process, right? So that is the activator of phase 1, is tissue damage. Okay, they both move towards the formation of factor X, like we already talked about. Okay, and then now for the differences between the intrinsic and extrinsic pathway. Intrinsic pathway, all of the clotting factors that are needed are found in the blood, so that's why it's called intrinsic. Okay, because they're all found in the blood. Okay, and this one is much slower. Okay, and then the extrinsic pathway factors, some of the factors are found outside of the blood, mainly one called tissue factor. And it's called tissue factor because it's only found in tissues. Okay, not in the blood. Okay, so this one's a lot faster. The more damage that you have, the more tissue factor is exposed to the blood, and that makes the clot happen faster. So this image shows the two pathways, the extrinsic pathway here. TF is tissue factor. Again, that forms factor 10, okay? Factor X right here. And this is factor X over here as well, okay? And really what happens is that when it becomes activated is the key thing that both steps lead to. They both lead to the activation of factor 10. That's what the factor 10A means, the 10th clotting protein in its activated form. Okay, so those are the two pathways for phase 1, right? And again, that end goal is the formation of activated factor 10. Okay, so again, we got factor 10, okay, is after the extrinsic and intrinsic pathways lead to factor 10, and then we lead to the formation of, or first we activate factor 10, that leads to the formation of prothrombinase, or what's also known as prothrombin activator, and that's this right here. Okay, so both intrinsic or extrinsic, they both end up in the same place at prothrombinase. Okay, you don't need to know all these little factors in here. The key is the main things in the text on the slides and the things that I said. Okay, phase 2 is very simple. We just made in the previous phase prothrombinase, right? So that prothrombinase or prothrombin activator, what it does is that goes and activates a protein that's always found in the blood called prothrombin, right? That's just one of our plasma proteins. It's always there. But as soon as it interacts with that prothrombinase that we just made in phase 1, that turns it into thrombin. Okay, so prothrombin is factor 2. When it, in its activated form, 2A, also known as thrombin. Okay, so it cleaves off really this bottom part of the protein. That's what prothrombinase does, right? Prothrombinase is an enzyme that turns this prothrombin into thrombin, right? It's much smaller here. It's been cleaved, and now it's an activated enzyme. So that's phase 2, formation of thrombin. Okay, thrombin is a catalyst. Okay, and so what happens is that transforms the soluble form of fibrinogen. Again, fibrinogen is a clotting protein that's just always in our blood, but it's not activated until it gets turned into fibrin. Okay, and so thrombin is the enzyme that does that. Thrombin turns fibrinogen into fibrin. Okay, this is the last step, so it doesn't convert it into an enzyme. It converts it into a clotting protein. And this is a sticky, fibrous protein that forms a web-like mesh. Okay, so then fibrin sticks together, forms long hair-like bands, and that glues all the platelets together. And this really creates the structural basis for the clot itself. And that's phase 3. So phase 3, we end in fibrin. Fibrin is the goal of phase 3, and that's the clot itself. Okay, so after the clot is formed, that's going to stop bleeding. That's going to stop all loss of blood. Now the next step will be to start trying to repair that tissue. Okay, so what we see, something that's really interesting, is that platelets contain contractile proteins. Okay, we've seen these before. They contain actin and myosin, just like in muscle. Right, so about half an hour to an hour after the injury occurs, actin and myosin start doing what we know them to do, which is contract. And that starts squeezing the broken part of the blood vessel together. That starts squeezing the clot together. And that starts squeezing serum out of the clot, compacts it, tightens it. Okay, and that actually pulls broken tissue back together as well. Okay, so then these platelets also release something called platelet-derived growth factor. Okay, so if it's a growth factor, makes sense. It's what it's going to do. It's going to cause growth, right? So endothelial cells also release a growth factor. Same idea, growth factor, but they release one from the vascular system, vascular endothelial growth factor. Right? So these two growth factors cause the cells to produce proteins, right? To divide, pretty much to heal tissue, right? So pretty amazing, right? Within 30 to 60 minutes of an injury, the body's already healing itself, right? It's retracting that clot, and the healing begins with the release of these growth factors that come from platelets and endothelial cells. Okay, so then the next step, and the last step here, is called fibrinolysis. Fibrinolysis is really just breaking down the clot, okay? So after the tissue is healed, we don't need to have the big clot there anymore. So what we have is a clot buster called plasmin, okay? And plasminogen is a protein that's always in our blood. So we just need to activate that plasminogen, turn it into plasmin, and plasmin is activated by an enzyme called tissue plasminogen activator, or TPA. This starts being released in high levels about 2 days after an injury, and then it takes about 2 days to finish. And the goal of this is to break up this clot, get all of this out of there, let the plasmin do its job, and remove that clot, because now we have healed tissue there. The clot's no longer needed. Okay, so I'm not going to go through this whole step here, or this whole recap here, but this would be a good opportunity for you to pause the video, go back into your notes, look at everything you wrote down, look and fill in the events that are happening during each step. Okay, so we start with vascular spasm, platelet activation, platelet plug, and we have phase 1, 2, and 3 of coagulation. And then we have clot retraction, clot repair, or tissue repair, and fibrinolysis, right? So this is kind of the whole process of events. Okay, so you want to fill in the key events that are happening in each step. The purpose, right? So why, it says purpose, why do each of those events happen? Okay, and then the important chemical mediators of each step. Okay, so take some time, fill that in. That'll be a good way to study this. Okay, so a few things about clotting. There are some pathological conditions that have to do with clotting. Okay, so thromboembolic conditions is kind of the general term for this, and really what this means are clotting conditions. Okay, so a few definitions are important here. So when you hear the word thrombus, this means a blood clot that forms in an unbroken vessel. Okay, so it's a clot that's not really supposed to be there. Okay, when it becomes an embolus, that was a thrombus, but then it broke away, and now it's traveling through the bloodstream. Okay, a thrombus that's traveling through the bloodstream. And then lastly, an embolism is when that same embolus, the blood clot that was traveling through the bloodstream, then gets stuck in an artery, causing a blockage. Okay, this is how heart attacks and strokes occur. Okay, so the causes of these thromboembolic conditions are atherosclerosis, or inflammation of the artery walls. That causes platelets to stick, and that can cause begin this whole process of coagulation in places where it doesn't need to happen. It can also happen due to stasis, if you're at bed rest or sitting long periods of time, like long plane rides. Right? That's why they recommend to do some little exercises. Keep the blood moving a little bit, because the clotting factors get kind of built up. They don't get washed away, and they can start causing a clot right there in your arteries. Okay, so let's talk about a few clinical applications here. Some really interesting drugs that you will most likely see all of these in your clinical career. Very, very common drugs. Blood clotting drugs are very common drugs in patients with atherosclerosis and cardiovascular disease, because they tend to clot too much. So most of them are on some clotting drugs at some point. Okay, so let's start with aspirin. Okay, aspirin is a simple one. We've all heard of it. Okay, what it does is it stops the formation of this guy right here. Right? Remember what that one was? Thromboxane A2. That's that same thromboxane A2 that we already talked about. Okay, that was one of the causes of that was platelet aggregation. Or sorry, one of the effects of that was platelet aggregation. Okay, thromboxane A2 goes. This is a platelet, by the way. Okay, this is a platelet, and that if thromboxane A2 is released, that goes to that same platelet, goes to other platelets, and causes them to start becoming activated and aggregate and become sticky and start causing a clot. Okay, so what aspirin does is it stops the formation of it by blocking this COX-1 enzyme it makes it so thromboxane A2 is not formed. Okay, definitely need to remember all of these clinical applications of these drugs. So that's the first one, aspirin. Second one is a common drug called Plavix, okay, also known as clopidogrel. That's the more pharmacological name. Plavix was the brand name. Okay, what this one does is it stops ADP from binding to platelets. Okay, so ADP was another one of those platelet aggregators and platelet activators, right? Cause platelet aggregation, platelet activation. So if we block ADP from binding to platelets, then we stop the formation of the platelet plug. We stop the formation of the clot. Okay, so aspirin is a very important drug for people with cardiovascular disease. It may reduce the risk of an MI or heart attack by up to 50% just by doing this little mechanism right here that you see. And so people at risk for heart attacks are always taking aspirin. Okay, let's look at heparin. Heparin is a catalyst. Okay, heparin catalyzes. It's a very common blood clotting drug. You'll see people on it after surgery. And what it does is it catalyzes antithrombin to block thrombin more effectively. Okay, so we didn't really talk about antithrombin, but antithrombin blocks thrombin from doing its job. And remember, thrombin's job was what? That's the one that turned fibrinogen into fibrin, right? So that was the last step of the clotting cascade. You can see it right here, thrombin turning fibrinogen into fibrin. Okay, so if we take the enzyme, this one here, antithrombin, and we wrap this heparin around it, heparin makes it so antithrombin holds tighter to thrombin, so it can't go and bind to fibrinogen and turn it into fibrin. Okay, so that's going to lead to less clotting as well. Okay, so that's drug number 3. Okay, and there's 2 other drugs. Coumadin is a very common blood thinning drug as well. This one indirectly inhibits the formation of thrombin. Okay, so look up there. It's also known as warfarin. Okay, everywhere you see a W, Coumadin and warfarin acts, right? We see it right here, right here, right here, right here, and right here, right? So warfarin blocks all of these different mechanisms. And what does that do? Eventually, in one way or another, that stops the formation of thrombin, right? It might stop it way upstream, might stop it downstream, but one way or another, see, it acts on both the extrinsic side with tissue factor, oops, and it also acts on the intrinsic side over here. Okay, so that's Coumadin. And then lastly, dabigatran or Pradaxa, okay, another common blood clotting drug. This directly inhibits thrombin. So we see the D right there, that's dabigatran. That one directly stops thrombin from doing its job and turning fibrinogen into fibrin. Okay, so we've got 1, 2, 3, 4, 5 drugs here. You need to know all of them, okay? 5 drugs. You should know exactly what they do. Okay, all right, so one other condition, which is can a lot of times be a fatal condition, is known as disseminated intravascular coagulation, also known as DIC. Okay, if you have a patient in the hospital that's getting DIC, it's a big problem. Okay, what happens is uncontrolled clotting in all blood vessels, followed by bleeding due to the rest of the blood not being able to clot. So pretty much clotting happens throughout the whole blood. So we use up all of our clotting factors, which then eventually clogs some blood vessels, leads to the blocked blood vessels, leads to some broken blood vessels, and now since all of our clotting factors are used up, there's no way to clot blood when those breaks happen, and the person usually bleeds out, leading to multiple organ failure and death. This is caused by sepsis, which is a systemic infection. Also can be caused by blood transfusions or, in rare cases, complications of pregnancy. Okay, a couple other bleeding disorders here. Thrombocytopenia. What this means is a low platelet count. Okay, this leads to bleeding in small vessels all over the body, also known as petechiae, and that just leads to, kind of looks like this. This is the petechiae picture of the baby with those little red dots. That's what it looks like when somebody has thrombocytopenia. Okay, and there's a platelet count of 50,000 per microliter or less. And the treatment is really to infuse platelets. Okay, and then impaired liver function will also lead to clotting problems. This could be caused by not having enough vitamin K in the diet, or it could be caused by inflamed or diseased liver, hepatitis, or cirrhosis. Okay, and all of this has to do with the fact that the liver makes the clotting proteins. So if the liver's not working right, it can't make those proteins. Okay, hemophilia. Hemophilias are hereditary blood bleeding disorders. That means typically means they're missing one or more of those clotting factors in that long cascade. Okay, and so really the way these are treated is that the people have to be transfused with clotting factors a lot, and it's a very, very costly disease. The average cost for these patients is $60,000 to $150,000 a year, and that's not the total payment. That's what they have to pay out of pocket after insurance. It's one of the most costly diseases to have. This is somebody with a large bleed just from a small bruise or something that would lead to a lot of bleeding in someone with hemophilia. So the bottom line is they don't have all the right proteins that they need due to a genetic mutation, and they can't do that clotting cascade if you're missing one of those key steps along the way. All right, and then lastly, a key thing in the in major injuries where a lot of bleeding has occurred is low blood volume, right? So if we've lost blood volume, the big problem is low blood pressure, right? So lost blood volume leads to low BP, which could lead to death. Okay, so the first step, if somebody's had a lot of bleeding, ambulance shows up, they're not going to take the time to figure out if they can find the right blood to put back in the person. The first thing they're going to do is they're going to try to get their blood pressure back up, right? So there's no time for blood typing and matching of blood right away on first thing on the scene. So they need to get the volume back up to avoid shock and death. And so what they do is they put a bunch of fluid in, right? So it needs to be normal saline or also an electrolyte solution. This is an example of one that's lactated ringers. Okay, you'll see that a lot in the hospital. The key with this is it has similar osmotic properties of the blood. It's isotonic to the blood, to the cells of the body. Okay, so that would be the first step. Once that gets their blood pressure back up, then they can figure out what blood type they need and they can get a proper transfusion. But we need to save their life with raising their blood pressure first. All right, guys, that's all. We'll see you for the IRAT and TRAT on Monday.